Hey, what's up, everybody? This is Sean and this is Hunter, and we are
Hey guys,
back with today's broadcast. What's up, buddy?
Hey, what's up, everybody? Same old. How are you doing?
I am doing well, and I'm super excited because, yeah, this has been a lot of fun. We're kind of doing a kind of a mutual presentation today, right? So that's gonna be pretty cool.
Yeah, we're doing it together. Should be a good time. I'm working on it past little while, so hope
Yeah.
everyone enjoys it.
Cool. Hey, so for those of you who are watching out on Facebook land and YouTube land and maybe on the website, stick around to the end of the broadcast. I'm gonna flash up on the not flash. I'm gonna put up on the page a slide that's gonna have a QR code for you to scan. That's gonna send you directly over to our site where you can get your free 1 hour of continuing education for this lecture. We're gonna be doing another broadcast as well on Thursday. The almost unanimous I mean, the
Yeah,
poll that we did was
yeah.
crazy. Um, the almost the unanimous choice from the community is going to be a broadcast on oxygenation, ventilation, and then driving pressures. So, how does that pertain to lung protective strategies? So, that's going to be on Thursday. I think it's the same time, isn't it? Noon?
Yeah, I think it is. No, that one I think is a little bit earlier. I think that one's like 10 or something. A little bit
Okay.
earlier, but
Either way, we're going to send an email out to everybody so you'll know exactly when that is. It'll be posted on the website over at FlightCrit.com as well as in the Facebook group. So be sure to check that out. Cool. Hunter, before we get going, do you have anything you want to add?
No, I don't. I don't. Nothing right now.
Cool. All right. Well, with that, let's get started. Today, we're going to be talking about emergent field placement of chest tubes / finger thoracotomy. And then we're going to transition into kind of the ICU side in the management of water seals, right? Or for those of you who, either the pleurovac or the atrium, whatever, right? They're basically the same thing, right? But how do we manage the water seals? So with that, let's go ahead and that's not what I wanted. Here we go. So chest tubes and water seals. So let's go ahead and get going. So basically what we are talking about today is not so much the placement of a chest tube in the hospital for, a kind of elective chest tube placement or things for like empyema or small pneumothorax or anything like that. This is, you're out in the field, you roll up on a scene, and you got a patient who is crashing in front of you, and you're going to do a blunt finger thoracotomy and or put in a chest tube. So what do we need to know about these particular patients? Well, before we dive into that, we are going to do a little bit about some anatomy and physiology review. And talk about some of the indications for this. And oh, look at that cut off. All right, well, hopefully that doesn't run into issues. So what we have over here on the left side of the screen are the indications for chest tube placement in the emergent setting in the field, right? So you've got a patient typically with some kind of chest trauma, whether it's blunt force trauma, penetrating trauma, or whatnot. They're hypotensive, they've got absent breath sounds, and they are either peri-arrest or they are a traumatic arrest, right? Traumatic arrest, we generally don't even worry about whether or not we can identify this is penetrating or blunt. Traumatic arrest in the field, we generally just take the lungs out of the equation. We do the blunt finger thoracotomy and see what happens, and then that way we know we're not dealing with a tension pneumothorax or a hemothorax. Right? So what you can see in this image here is you can see this big pneumo. You can see this line of demarcation on both sides. This is bilateral tension or bilateral pneumothorax. And if the patient is now hypotensive or peri-arrest, then we consider this a tension pneumothorax. Generally, that is indicated by a patient who is hypotensive, right? There's other reasons why in the hospital they would place a chest tube. Again, like I already said, empyema patients who are post-surgical and they're going to be having drains, or what you might encounter in the out-of-hospital setting is a patient who you are going to pick up at a small outer-lying clinic. They have a small pneumothorax, usually less than about 20%, but you are having to fly them from said altitude, wherever you happen to be, to a higher altitude. You're going to have a significant change in pressure, and that lung, that pneumo, is likely to expand to the point of causing them complications, right? And that's going to be a judgment call on your part. Whether you're in a pressurized or unpressurized cabin is going to make all the difference in the world. But what kind of elevation change are you going to experience during your transport, and whether that is going to likely have an effect on your patient. Remember, the greatest changes in pressures are at low altitude. So if you're going from sea level to 5,000 feet, that might be a significant change to affect your patient. But if you're going from 10,000 feet to 14,000 feet, that may not have quite the same kind of effect as if you're starting from sea level. All right. So next. Basically, what I want to talk about here is the fact that we need to have a refresher on the organs that we're are potentially dealing with, right? So behind the rib cage, which protects the lungs, the hearts, the great vessels, we also have some protection applied to the diaphragm, and then remember that just underneath the diaphragm are our abdominal organs. So the diaphragm is the floor of the thoracic cavity and the ceiling of the abdominal cavity. And one of the things you're going to see in the next slide here is that those abdominal organs are tucked up inside of that diaphragm. That diaphragm is a dome-shaped structure, and that liver and the spleen and the intestines are kind of tucked up underneath it. So when we start talking about proper placement of the chest tube, it's essential that we are making sure that we are staying high enough in that thoracic cavity to avoid inadvertently puncturing and lacerating the diaphragm and subsequently those organs that are underneath it. So that is the big concern with placement, incorrect placement of the chest tube. All right, just again, a quick recap. We have, let me go ahead and move this out of the way. I'm gonna go ahead and close this picture down. So we have 12 thoracic ribs, right? There's 7 true ribs, 3 false ribs, and 2 floating ribs. So if I'm over here and we count these 1, 2, 3, 4, 5, 6, 7, you can see the 7th rib actually does come up and connect into the sternum. And then we got 8, 9, and 10, which connect into the cartilage of the 7th rib, and then we've got the 2 floating ribs below. That's that's a review of the anatomy of the rib cage, right? So when we are placing our chest tube, we need to make sure that we are staying in that, what we say, the 4th or 5th intercostal space. I generally like to stay in the 4th, or aim for the 4th intercostal space, and we'll get to that a little bit later as to why. All right. So remember that diaphragm is going to lower and is going to rise with inspiration and exhalation. Generally, well, there's a lot of different kind of opinions out there, but that diaphragm during complete exhalation can rise to the level of the fifth rib, or that, I'm sorry, 6th rib or 5th intercostal space, right? So during inhalation, deep inhalation, the diaphragm can drop down to that 9th or 10th rib. So in the hospital, we'll ask our patients to take a nice deep breath while we do this procedure so that we are dropping that diaphragm and lowering those vital organs, those abdominal organs, down out of the way. However, in the field, when we have a patient who's peri-arrest or arrest, they're not going to necessarily be able to respond. So that's why it is important that we are making sure we are in the proper anatomical landmark. So that 4th or 5th intercostal space. It can be very challenging in the out-of-hospital setting to identify that proper intercostal space by palpating the ribs and palpating the intercostal space. So my recommendation is that you aim for that 4th intercostal space. If you end up a little high, there's no harm, no foul. If you end up a little low and you end up in the 5th intercostal space, you're still within that safe triangle. Okay. This is a chest x-ray of a patient who obviously took a nice full deep breath, and you can see how that diaphragm is flat. I've counted out the ribs here. You can almost see down to the 11th rib, right? Plenty of space. We don't have that luxury in the field setting. Okay, so anatomical landmarks, right? There's this triangle of safety you'll hear providers refer to. The triangle of safety is bordered by the anterior margin of the latimus dorsus, the lateral margin of the pectoralis major, and then the 5th intercostal space, which generally is believed to be horizontal with the nipple line, or in women, the inframammary fold. So that forms that triangle of safety. This is where you are trying to place do your blunt finger thoracotomy or place your chest tube. Right? Positioning is everything, and there's some really good pictures out on the internet that I couldn't grab. But the way you want to try and position your patient is with the arm up, tucked behind their head. That pulls those anatomical structures, the pectoralis major, the latimus dorsus, the skin, pulls them into a superior position, exposing that safety triangle best. If you can't get their arm all the way up because of trauma, or a fused joint or whatever, trying to get it at least to a horizontal position will expose that area and give you the best option of getting into that safe anatomical landmark. Okay. Prior to actually doing your cut, if you're going to be placing a chest tube, you want to clamp your chest tube, right? So using your Kellys, you're going to clamp the end, and then whether you have another set of Kellys or you've got just some hemostats, you want to clamp the distal end as well to be able to control blood flow during placement of the chest tube. There's some caveats to this that we're going to talk about in a little bit. Okay, so anatomical landmarks, right? We've already identified fourth or fifth intercostal space. Generally, it's going to be about level with the nipple line. And then as you are inserting your chest tube or doing your finger thoracotomy, you want to make sure that you are going over the rib. So you're going to palpate, if you're going for that fourth intercostal space, you want to palpate the fifth rib, and then you are going to be inserting the tube or your finger over the top of that rib. And here's why, right? We've all seen this. You've got the neurovascular bundle that sits below that rib. So vein, artery, nerve, lymphatic. You don't want to cut any of those vessels. So that's why we go above. So how are you going to do this? Some providers will say do a large, generous cut. Others will say make a small cut just big enough in order to get your Kellys or your tube through. Whatever your protocols say, that's what you're going to do. You're going to make a horizontal cut along the rib. Okay? You don't want to try and cut into that pleural space because you want that to be a controlled puncture. So you're going to make your insertion along that fifth intercostal or that fifth rib, just below the fourth intercostal space, and then you're going to take your Kellys, holding the end with your fingertips so that you cannot puncture too far into the chest wall. You're going to force those Kellys through the tissue. You will feel resistance from that pleural cavity, that pleural sac, and there is a tactile pop that happens when you push into the pleural space. At that point, you're going to stop. You spread your Kellys, blunt dissecting that membrane. As you are pulling the Kellys back out, it's going to open up that membrane. I will tell you, having tried to do a quote-unquote blunt finger thoracotomy without using an instrument like the Kellys, it's impossible. Or I was not able to do it. It's called a blunt finger thoracotomy. However, you're still going to need some kind of an instrument, scalpels and a Kelly or a pair of hemostats at the very minimal, at the very, very least. So you've punctured through the pleural space. You've now gotten into that intrapleural cavity. The Kellys have been spread. That's blunt dissecting that track. As you are pulling the Kellys out, your finger needs to go directly into that same hole. You never want to lose that track. The skin can move, the pleural sac can move, and you can lose that space into the pleural cavity. You will insert your finger into that pleural space. You should have tactile feel of the ribs on the inside of the chest wall. And you might also possibly be able to palpate the expansion of the lung. You should not feel any other organs. That is your proof that you are in the pleural cavity. Okay? If you feel organs, then you are not in the pleural cavity, and you need to stop what you're doing and not try to insert that chest tube. Once you have done this, once you have punctured the pleural cavity with your instrument, you've blunt dissected with your finger, you have essentially completed the life-saving procedure. You have decompressed that chest. That lung should begin to automatically expand. Might require a little bit of positive pressure. But at that point, the patient's status should begin to improve almost immediately. At this point, you could simply put on a chest seal and be done with it. There are a few circumstances, primarily if you have a massive hemothorax, where it would be prudent to place a chest tube. So a massive hemothorax is considered initial somewhere between 1,000 and 1,500 mLs of blood loss from the chest cavity upon initial insertion of that finger thoracotomy. At that point, you would want to insert the chest tube and then clamp it to prevent exsanguination. You don't want the patient to lose all their blood volume. Now, in the field, you're not going to have the ability to measure that, so it's going to be a rough estimate. Does this look like a large amount of blood that's pouring out of the patient's chest? I'm going to put in a chest tube. I'm going to clamp it. I'm going to control that bleeding. Obviously, you'll still do all of your other procedures to secure the tube in place, but that will allow you to at least partially relieve some of that tension, hopefully get some improved circulation, some improved ventilation and oxygenation, but prevent the patient from bleeding to death from blood that's being lost into their chest cavity. All right, if you are going to place this chest tube, you're going to insert it aiming proximally or superiorly and distally, not proximally, superiorly and posteriorly or dorsally. That's how you'll hear it referred to. And the key is you want to insert that chest tube to the point that these eyelets are no longer visible outside the chest wall. At that point, you would then secure the chest tube in place, whether you're going to put Vaseline gauze around the insertion site, then cover it with some sterile gauze and tape it or suture it. That's going to be up to you and up to your protocol. I will tell you, in the field, generally we try to say we're just going to tape the tube down, but our patients are usually very sweaty, they're very bloody, and so that tape doesn't often stick too well. If that's the case, make sure that you go ahead and throw a couple stitches in there, a couple sutures in there, and secure that tube in place. If you have one and this is a pneumothorax, putting a Heimlich valve on there is a great tool. If not, you can leave the chest tube open to air and just let it vent. What you don't want to have happen is not control your scene, not control the receiving facility, not have that tube very well secured and have it inadvertently pulled out at any point throughout your care with this patient. Now,
bad day
remember,
right there.
What's that?
I said that's a bad day right there.
That's a bad day. Yeah, we don't want that to happen, right? We want that tube in place and nice and secure. We don't want to have the patient have to go through the whole, the procedure again. Now, remember, I said that you're going to likely be using your Kellys to blunt dissect into that pleural space. What I don't want to have happen, and this actually occurred to me, is I had one pair of Kellys performing the procedure. My partner grabbed the other set of Kellys, thinking that I was going to then take my Kellys that I just used to blunt dissect into the chest wall and clamp the end of the tube. The distal end of the tube was handed to me with the Kellys in place, and it looked just like this, and I placed the chest tube into the patient's chest backwards. Fortunately, it was still draining, wasn't a big deal, but just be aware of that, right? Make sure that you are, if you are assisting your partner with placement of the chest tube, that you are handing the tube to them in a way that's not going to cause confusion. So back to this picture here. I just wanted to kind of show this up to everyone. This placement looks pretty darn low to me. I would be a little concerned about putting a chest tube into that gentleman's chest with the at that location. And then lastly, this CT here. If we count these ribs, this is 1, this is 2, 3, 4, 5, 6, 7, 8. This tube has been placed into the 7th intercostal space, way too low, right? Like you can imagine, the risk of going too low is that you perforate the diaphragm and perforate the liver. Never a good day for us or for our patients. Hunter, anything you want to add to that portion before we move on to your section?
Now, like you said, that position, I think once you, I don't know, look at a chest x-ray, you look at a CT scan, I mean, especially with, when you look at the diaphragm, inspiration versus expiration, you see how easy it is to displace those ribs. And if you guys are ever curious, look at a chest x-ray on inspiration versus expiration, and you'll see just how all those organs kind of get squished together, and it almost looks more like a, quote unquote fluffy x-ray, but it's really just the expiration versus inspiration. So, no, I totally agree.
Awesome. Cool. Well, take it away with atriums. Water
All
seals.
righty. Yes. Water seal.
Water seal.
All right. All right, quick down and dirty, guys, on the chest tube, atrium, pleurovax, whatever you use, essentially the water seal. So I kind of just made these 3 little bottle. I think if you think as the actual chest tube device as a 3-bottle system, it makes it a lot easier. So if you imagine, if you look at, let's just leave that up. Let's look at bottle number 2. So if you look at bottle number 2, that's how it all started, 1 bottle. Air comes in, bubbles out, and then goes into the atmosphere. Well, that worked great, right? There was no reason to change it from bottle 2 to any other bottles. But the issue is, if you're also escaping fluid, blood, anything like that, you create more pressure in that bottle, so it's hard to evacuate the air. Good example of this is try and blow air into a canister that is just a little bit full of water versus completely full, right? It's a lot harder to generate air to push in there to create that bubble. So that's why then they had a 2-bottle system. The first bottle collected blood, fluid, whatever it might be, your serous fluid, anything like that. Then the air would come into that second bottle, filter through the water, and go into the environment. Why they added a 3rd bottle is for suction, right? We want to get that last amount of air out of there and into the atmosphere. So that actually is what we're seeing now in the normal chest tube devices that we see now. So if you kind of break it down to a 3-bottle system, that kind of complicated chest tube device actually looks a lot easier when you think that one chamber is collecting fluid, blood, whatever it might be. The other chamber is filtering that air so it doesn't go back, right? That it has to go through the water so it doesn't go back into the chest. When it goes through the water, it bubbles through, and then you have suction to try and get the remaining whatever you're trying to evacuate out of that system. So next time you look at one of these, think about the 3-bottle system. I mean, that's why, if you ever heard the old saying, like you can just put a straw underwater and put it in the chest, the air will go through the straw, bubble through the water, and go out in the environment. That was a whole 1-bottle system. You're creating a chest wall, essentially. But the other 2 bottles we add to it is just helpful for draining and then also for suctioning. Quick down and dirty of managing. We won't go super into this. People in the hospital understand kind of this. Some of us in the transport system is a little bit different. You always want to make sure it's not kinked. I always say treat these like a central line. If you're going to CT scan within the hospital, or if you guys are transporting the ambulance and or the aircraft, always making sure it's not kinked. It's pretty obvious, but when we strap these patients in, that can happen pretty easily. You want to make sure you have a nice line there. Always make sure it's below the patient best you can. Now I understand going to transport in the hospital, going to scan, or if we're transporting out in the field, that's not always possible. And I see these get put up on patients all the time. The biggest thing, if you're trying to drain blood or anything like that, it works by gravity, right? So keep it below them. It'll go out that way. And it's also a high pressure, low pressure system with our air. But if it's a small commute, I don't think it's the end of the world. And this is just my opinion. But if you're managing them long-term, it needs below that patient. Always making sure there's no loops. We want that blood to move nicely from the patient down into the system. We don't want to go through a roller coaster ride or anything like that. Let's talk about bubbling. So as you can see in this picture, this guy's got pretty good bubbling. For people listening on the podcast, it's just that massive amount of bubbling happening in that water seal system. So let's talk about bubbling. Is it good or is it bad? When should I worry? When should I not, maybe? So when you're placing a fresh chest tube, if you're ever in there, check it out. You'll see that if you have it hooked up to the atrium, it'll bubble like crazy. And the reason for that is because you're escaping all that air. So it's normal for it to bubble right away. I mean, it might even look like a hot tub. You're escaping that air, you're releasing that tension, and that's great. If if you've ever seen a chest tube put in, if you have a real tension, sometimes putting those in, you'll hear that rush of air. So that's normal at first. That's not a huge deal. But now if you're starting to transport a patient or you're taking care of a patient and you're getting sign off and you go look and you see bubbling and it wasn't reported to you, that's a different story. We assume that that lung has relatively reinflated and there's less air, so we shouldn't have so much bubbling because we don't have that huge rush of air anymore. So then you look for a leak, right? Because that's usually what's happening. So I always say start at your patient, look at that dressing, right? Usually it's a nice occlusive dressing. Make sure it's around the tube because that insertion site, if they have a huge insertion site, and maybe it was done in the field, it wasn't sutured, whatever it might be, air can be escaping other places. So make sure that dressing looks really nice. Feel around the dressing. Make sure there's no crepitus and the air escaping under the skin. And then you're just going to go down your tube, right? I don't know. I'm sure a lot of you guys have done this. But you're going to clamp your tube. Obviously, you're not clamping it and talking to your friend because you're going to retension that patient. So make sure you're just clamping it for a little bit and watch the bubbling. As you go down the tube, if that bubbling stops, you have found the leak. It's relatively where you found the leak, okay? It might not be exactly where your finger is, but you relatively found the leak. Sometimes quick and easy is putting an occlusive tape on that or something like that. If you go down the tube all the way down and now you're in the atrium itself or the chest tube system and you're clamping and you went down the whole tube and you're like, hey, it kept bubbling the whole time, I would say that if your confidence not in the patient, now it's not in the tube, it's within the system itself. Sometimes they have cracks. They fall over. I mean, if you haven't, kicked over a chest tube in your life, you'll do it, every day. But, they fall over all the time and it's plastic. So there could be a crack in the chest tube atrium or system itself. So that might need to be replaced. And the last couple other things I wanted to say is that sometimes leaks are known. So if you're getting report, if you're in the ICU or if we're transporting this patient and you see bubbling or you see a leak, I guess, sometimes they're known. And if that leak is happening and that patient's oxygenating, ventilating well, they're getting good VTEs and pressures with on your ventilator, or you just have no real concerns, sometimes small leaks are okay. Again, this is my personal opinion, and they're just kind of known. So it's more, sometimes it can be more hurtful to that patient to try and replace the whole chest tube or reconnect it, risk infection, stuff like that. So sometimes just asking if you see it, be like, hey, did we know he has a leak? Whether you're doing shift report or if you're transporting this patient, like I said, sometimes they're known. If you look at the chamber itself, for people that are watching, I put an arrow, but if people that are listening on the chamber, if you look at the next one, there's a 1 through 5 on the water seal chamber itself. That bubbling, as it gets worse and worse and worse, will go from 1 to 5. So if you have a really bad leak, you're going to see that 5 area having bubbles. If it's just a run-of-the-mill leak, it's going to be more in that 1 area. The other thing I like to say is if your patient coughs and anything like that, yes, you're going to have bubbles. That's normal. It's an X-force of air, just like when you first put in the chest tube. It's a lot of air at once. You're going to see some bubbling. But just a good indicator, if you're looking at that window and you see the bubbling around 1 or 2 and your patient looks fine, they're oxygenating, ventilating well, it might just be a minor leak, something you don't have to worry about. Now, if you're in that 5 range and you start to have high pressure alarms, your patient's exhale tidal volumes, or they're not ventilating well, they're not oxygenating, now we might have a big enough leak where that air is staying in that cavity, and something you want to worry about. Next is titling. So titling is, let's see if she's going to work for me. I'll just play it. So titling, for people that are watching, but I'm sure other people have seen that are listening, is that ball going up or down within that chest tube system. So titling, I think, is a big indicator to see how well your chest tube system is working. If you're not intubated, when your patient breathes in, and you can just go into the ICU or an ER and watch this yourself, but as your patient breathes in, diaphragm's going to come down. It's going to create a negative pressure, and that ball's going to go up, and then they breathe out, and the ball's going to go down. So up and then down. So it's that nice up and down that's going to follow that patient with their respirations. Now, if they're intubated and you're pushing pressure into the lungs, that's going to push the ball down. So it's opposite. I don't think that's anything you have to memorize, but it's just helpful just to remember that when they breathe in, non-invasive, it should come up and down. So titling, I think, is, again, personal opinion here, something that just shows that the system is working well. Reasons you might not have titling that are bad, there's a kink. Next time you have a chest tube, clamp that chest and watch. You won't have any titling. So maybe you're kinking that off somewhere. Maybe the patient's on it on their side and they're kinking it off. somewhere in the system. Another thing is if you have an intubated patient, which a lot of us were doing this with COVID, and they're on high amounts of PEEP, sometimes those high amounts of PEEP is keeping those lungs. There's so much pressure in there that you'll get minimal or less titling with that. So that could be a normal finding. Also, towards the end of therapy with pneumothorax, as that lung inflates, there's less air to push into that system. So when a lung is fully reinflated, sometimes you're going to have minimal to absent titling. So I think it's always good to make sure that if you're not having titling, you're not missing anything that's bad. But there are a couple normal things that will cause no titling that are totally fine. Another thing, if you imagine if you have a huge air leak, you're going to get no titling because you have no air going into that system, and it's going to create no titling. So that's another indicator. If you have bubbling and no titling, guarantee you got a big air leak, right? So checking that out, or it's just not connected to the patient, and you're just having a hot tub in there, and then the chest tube's out. So I think just check your titling. I don't think it has to be a huge, I think in the video for people that are watching, this is really good titling. It doesn't have to be that great. Sometimes you see it go all the way up and come all the way back down. Depends how deep your patient's breathing. But I think just some titling is something you want to have. Okay, let's talk about suction on the chest tube system. So suction, I think, is very provider dependent. Some providers want portable suction when you're going to CAT scan in the hospital. Some of them want it when you're going to the aircraft, and it's going to be like 5 minutes. It depends. I think it's provider dependent. Again, personal opinion. There's definitely times where suction is needed. So let's just talk about suction in general. So if you can see this orange bevel for people that are watching, you want to make sure that's out. When I let go and I take suction off, you see how that went away in the window. So to know that you have suction is that bevel is out in that window. Okay, if you don't have suction, you'll see that orange bevel will go away. For people that are listening, there's right under your dry suction numbers, there's an orange bevel and there's an arrow to where it should be. Now, I've seen this all the time in the hospital, is everyone wants to set wall suction to a certain number. They're like, we have to set the wall suction to 120 or 200. It doesn't matter, okay? This is a dry suction system. So you want to ensure that whatever your provider wants, it's usually that -20, is preset. You need just enough suction to bring that orange bevel out. Now, I'm not saying you don't need any wall suction. You need some, but you don't have to crank it up, okay? It's not going to be abnormal for them to give you no set number of wall suction. The wall suction doesn't matter. You need just enough wall suction to bring that bevel out, okay? It's the dry suction within the system that we care about. Now, talking about suction, again, provider dependent. If you are, let's say your patient in the hospital is coming off suction, or let's say we're transporting this patient, you're like, I'm not going to put that guy on suction. I'm trying to use suction for the OG tube or whatever else they have going on. Just be very apparent with this, right? Because if you take your patient off suction, they're still going to escape air, but now that air has an easier way to stay in the chest cavity. So watch them, right? Do they have difficulty breathing, chest pain? Are their SATs decreasing? Are they going up on their oxygen requirements? That's all signs of retensioning, right? There's more air in there now. It might not be a tension, but there's enough to maybe cause more and more of that simple pneumothorax. If your patient's intubated, you're in the ICU or transporting an intubated patient, you're watching your pressures, right? If your pips are all of a sudden jumping up, and you're like, I can't ventilate this guy anymore, and all that, put them back on suction. Get that air out, escape it, and you'll be surprised. You look at that little water shield chamber, you'll see some bubbling. You got that air back out. So again, I think suction's a provider-dependent thing. I always ask, do you want us to take them on suction? Sometimes they're like, no big deal. But if you're choosing, I don't think anyone's ever going to fault you for putting someone on suction in the transport environment. But if you're choosing not to put them on suction, you need to just be more aware, right? Just make sure that you're not creating more air in that system. If your patient starts to look like dirt and you're having issues ventilating them, or you're having high pressures on the system, they're getting more tachycardic, whatever, put them back on suction. Figure out a way to do that. I don't want to say that suction is like nothing goes wrong with it. Sometimes suction can cause injuries, right? Sometimes suction can cause bleeding and other injuries within the system. So it's not a thing that we just do willy-nilly and say, why don't we put everyone on suction then? Well, there is times that suction can cause injury. And when you take these guys off suction, you just go to a water seal. You'll probably see that we are doing repeat chest x-rays in the hospital to see how well that lung is taking to that and making sure that lung is staying nice and inflated. So like I said, I think it's provider dependent. Always ask. I don't think anyone's going to fault you for keeping them on suction. If they've been on suction for like 10 days and they're doing fine, I don't see any reason to go back on. But just make sure you're checking that. Okay, so let's talk about if the chest tube comes out. So if the chest tube comes out of the patient, this is pretty crazy. I have seen it happen, but it happens. So if the chest tube comes out, we always teach what? Sterile-occlusive dressing. The reason for that, when you put that sterile-occlusive dressing on, it still creates the chest wall. We don't want air when you breathe in. I don't want air going through this hole back into the chest cavity and then having an issue getting out. I want my air to go through my mouth, out there, through my mouth, out there. So what that seal does is it allows negative pressure as you inhale to flow from the mouth out the chest. Okay, I don't want it going in the chest and then having issues coming out because now you got a tension on you all over again. So that 3-sided, sometimes 4-sided, whatever it is, sterile-occlusive dressing that's why we do it, right? We want the air to come through the mouth, out through the chest. So if you have a pneumothorax, right, not a hemo, not any of that stuff, let's just say it's just air, and this falls out. Well, if you did a successful chest tube, right, we saved their life. We got all the air out. The tension should be gone. There's going to be some residual air, but they should be able to ventilate, right? The lungs should have now space to ventilate. So sometimes if this happened, if you're in the field or if you're away from the bed, the ICU as a nurse or something like that, you might be able to just wait and watch on this. They might not need a chest tube put in right away, right? Because you already escaped all that air that killed them. I'm not saying it's not going to retention, but you might be okay just to wait and watch. Again, that's personal opinion, but I've seen that happen where it's like, let's just wait and watch. Now, if it's in people that can do finger thoracotomies or thoracostomies, if you think about this, now you have an open pneumothorax. That's all you just created. You just created an open pneumothorax. You created a window into that thoracic cavity. So if your patient looks like they're going to start tensioning again, well, put your finger in there and escape that air, right? You're doing that life-saving measure, and then you might need to put a chest tube back in. But for people that can do that, I'm not telling everyone to go try and do a finger, but I'm saying if you have that policy, you now have that open window, right? You have the ability to just put your finger back in there like you do with the finger thoracostomy and reopen that area and try and release the blood or the air. Now, this is for attention. If a chest tube falls out and it's a hemothorax and there's a bunch of blood in there, that concerns me because now there's really no easy way for that blood to get out. The whole reason of the tube was to get the blood out. So if it's a hemothorax or another issue with a bunch of fluid in the chest and that chest tube falls out, again, personal opinion, but I would say that another chest tube has to go in to drain that out. Now, again, you save their life. If you have a massive tension hemothorax and you put a bunch of a chest tube in there and you evacuate all that blood, now that lung can inflate, but there's a chance there's still some kind of, maybe there's an artery that's bleeding or an intercostal muscle or something that might still be bleeding, so you might need that chest tube to go back in there. But again, it's with the air, as far as a pneumo goes, you've already escaped the tension, so you might be able to wait and watch with that. Last but not least, people that like to talk about chest x-rays, and we look forward to talking about them with you guys soon. Chest x-rays are kind of one of the best standards, I would say, to confirm these chest tube placement. I don't get super fancy with it. If you look at a chest tube, next time you check it out, there's this radio opaque line. It's usually a certain color, white, blue, whatever it is. And you'll see interruptions in that line. Those are the holes. When you do a chest x-ray, you just want to make sure you see all the holes within the chest tube cavity. I think it's kind of crazy when people are trying to count all the holes. Just make sure all the holes are within the cavity. If you look at it and you see the out line of the thoracic cavity, and then you see kind of what would be the subcutaneous or the tissue, and you see just these little breaks in the line, that chest tube's not in all the way. So that's the biggest thing when you're doing it. We want all those holes within the chest tube cavity, and those are seen as interruptions in that nice radio opaque line, and that's how we can see it. Just like a central line will have that, OGs have it, anything like that that's going to be confirmed with the chest x-ray will have that nice line on it to confirm. So just look for interruptions in it and just make sure all those interruptions and or holes, whatever you want to call it, are within the cavity. And me and Sean are looking forward to doing some chest x-ray interpretation someday. So we'll see. And that's all I got, guys, on the system itself. I think they look creepy, but if you think about that 3-bottle system, it makes it a lot easier. So that's all I got, Sean. I don't think I'm hearing you right now.
There we go. I just had to unmute
There
because
you go.
I didn't want to make noise while you're talking.
Oh,
No, I
I
really
appreciate
appreciate that. For those of you who maybe can't, don't have a microphone or whatever, or whatever, what questions do you have? That was awesome. And while I'm just waiting to see if anybody does have any questions that they want to kind of add to the conversation, right? Here are those eyelets holes, and you can kind of see that radio opaque line that Hunter was
Yeah,
talking about
see
on the
blue on
chest tube,
there. Yep.
right? So you
Yep.
don't need to worry about counting them all, but that blue line right there will show up on the chest X-ray. You'll be able to see where that tube is going up into the chest. So good stuff. Hunter, what is your thoughts? So what's been your experience with chest tubes and hemothorax, with the hemothorax on suction? Because like we
Yeah.
talked about,
So
it can make it worse.
yeah, it can. Like I said, I don't think suction. That's why I say don't. We're not putting suction on everyone just because why. It's not one of those things like why wouldn't you put them on suction? Because there's always risk to that. I mean, think about an OG tube. We like to put air and put air into the belly so that OG tube's not sitting on the stomach creating an ulcer or something like that. Just like that, chest tubes, depending on where they're at, they can cause injury within that thoracic cavity with that negative flow of suction going on. So, like I said, it's provider dependent. I think the thing you'll see is as soon as we can come off suction, suction's off.
Right.
It's a trial thing, in the hospital. We take them off, do some chest X-rays, how they doing, but it's not something that it's a weaning thing. And if you can come off suction, it's a good thing. You're going towards getting that tube out. So yeah, I don't know. I think it's very provider dependent, and there is a degree of injuries that can happen from chest tube suction. I agree.
Right. Yeah. Well, and in the field, we are the providers, right? We're
Right.
likely going to have policies, and we're going to have, guidelines, I should say, to go by. But, we as the critical care transport providers are out there. We may not have communications. We're the ones that need to make these decisions. And we do it together. We talk with our partners. What do you think? I've done a finger thoracotomy, and I've felt that lung almost fully inflate, against my finger.
Right.
I was actually a little surprised because the patient was not on was not spontaneous, was not on positive pressure. So you're right. You put that finger in there, you relieve that pressure, and suddenly it expands. And so to put that tube in, well, are you doing parenchymal damage to the lung tissue? What benefit are you getting? We talk about low intermittent suction from, and you see that in the hospital. We don't have that in our aircraft. We have the ability to adjust the amount of suction. And granted, we're not running it through an atrium. We're not running it through a water seal, right? We're just connecting directly to our suction catheter, so we can dial the pressure down and evacuate that air, because it's not like we're trying to suck a peanut out of somebody's throat, where generally our suction is set very high because we're clearing the airway. We need to remember to turn that down to a lower setting, evacuate that air, and then potentially, like you said, turn it off.
Right. Exactly. Yep. And the biggest thing is, definitely in the hospital, we see it a lot for people that are listening that are ICU nurses, ER nurses, but same with the transport. It's that wall suction, that number on the wall suction. It does not, I'm not saying it doesn't matter, just needs to be enough to make sure that bubbles out. But that's why there is the chest tube box, whatever you want to call it, because it has the dry suction in there. So
right.
yeah.
My experience, kind of going back to what you were talking about, securing the tube, and I already talked about this, was, the first time I ever placed a chest tube, I sutured it in, right? And by the time I was done suturing, my partner was already on to the next thing, because she just placed the chest tube and taped it down. And then the next time I tried that, the patient was a bloody mess, and I just tried to tape it, and tube came out. So preferably, we'd like to just simply tape these down and secure them that way, because it's quick in the field when we're just trying to get on to the next thing, get the patient to the hospital. But you might need to just take that extra 60 seconds and throw a couple stitches in and tie up that tube to keep it from, well, like I showed you the picture where the tube was pulled out.
Yeah.
And
right.
just being careful, right? Because we're trying to do what's good for the patient, and there's few procedures I feel like that we can do in the field that will absolutely save a person's life, and this is one of them. Doing that blunt finger thoracotomy on that patient who's tensioning is absolutely one of those things that we can do that will save a life. So,
Right.
if you don't have this in your guidelines, you should be consulting with your physician advisor and working on getting it in your guidelines. Gone are the days really where needle decompression is acceptable. I know that in my mind, if somebody's needled, I'm likely putting in a chest tube. Or I'm likely doing finger thoracotomy. Especially if the EMS tells me, they had blunt chest and I had no breath sounds and I needled their chest and it got better. Their blood pressure came up and they could breathe easier. And now they're looking like they're in respiratory distress again. I'm not doing another needle. I'm putting a larger hole in their chest.
Right. Yeah, that's definitely something, if you're in the hospital and in the trauma bay and they come in and they say that, it's not unlikely for those chest tube trays to start coming out. And because, like I said, and that's the thing, is it air, is it blood? We're dealing with trauma patients. So how well is that needle going to do with the hemothorax versus putting in the chest tube? So
right. They kink, they clot. Half the time they don't even make it into the chest cavity. Right. So cool. I'm gonna open it up.
And I think that's the thing is, you can what's that? I was saying, kind of as those lungs re-expand, you'll see it bend. It bends those needles. Okay. So, I always do when people put plungers on, they're trying to take air out. But if the lung is re-expanding and pushing on that needle, well, you just bent the needle and you're not getting much out. So
right.
A chest tube is probably going to be warranted in that patient's future pretty quick.
Yeah. I guess the benefit to that, or at least the thought process could be that if you've now expanded the lung enough to pinch off that catheter, then the lung is probably fairly well re-expanded.
Right.
I've seen where people do the needle decompression, they don't get a whole lot of air out, they still get absent breath sounds, so they stick a 60 cc syringe on there, and they're physically actively evacuating that air, and every time they pull out that plunger, and you can do it with a 3-way stopcock too, so you don't have to disconnect. 3-way stopcock, and you pull it out and then vent it, and it'll pull 10, 20 times before that lung expands enough to basically pinch off the tube, and then oh, okay, it's expanded, the lung is expanded, so we're in good shape. So right on. Does anybody else have any other questions that you'd like to have answered?
Yeah, and if you guys don't have any right now, feel free to always reach out to us on our Facebook, on our Instagram. Anything like that. Especially people listening on the podcast, shoot us. Me and Sean are pretty close to our phones, so we like to say that we can give answers pretty quickly. So
that's absolutely right. All right, cool. So for those of you who are watching, go ahead and scan that QR code. I got 2 images up here on the screen. I do not want that. Let's see what happens if I add them. Well, anyway, that was not supposed to be the case. This was supposed to add. Here, I'll put Hunter up twice. If I can do it. Anyway, scan that QR code, and you won't have to look at me twice next time. That will take you directly over to our education site. Complete the survey, or the quiz, followed by the survey, and you will get a free CE if done within the next 24 hours. So for those of you who are watching this on the replay, I will leave that up. It is now 1 p.m. Mountain Time, 3 p.m. Eastern Time. So sometime tomorrow, late afternoon, after right around 3 p.m. Eastern Time, that QR code will still be active, but it won't route to this course. You won't be able to get the free CE. So 24 hours, go get your free CE. And so you have a real quick question. Missed most of the presentation. Stuck working. Yeah, work's a bummer, right? When it gets in the way of our broadcast. No, I'm just kidding. Will you post this for review later? Yes, the The video will remain up live on our social media pages for the next 24 hours. So you'll have the ability to scan that code and go over and grab your free CE. All right, guys, that is all I have. I'm going to leave this up. I wish I got to figure out how to bring Hunter back in here. But he can hear you.
And I think, Sean, we were kind of talking, kind of moving forward, guys. We will be giving CEs for everyone almost, nurses, medics.
Yes.
Sean was not helping out my nursing folks, so I'm trying to get us going here, guys. So we should be able to give out CEs. So I know those nurses working in those critical areas need a lot of CEs because I need a lot of CEs. So we will be giving them to both. So
yes, we have applied for our California Board of Nursing continuing education provider certificate. So usually about 3 months for that to come through. We have a special going on right now. So if you are looking for a review course for FPC, CCPC, or CFRN, you can get lifetime access for roughly about the next 3 months while we're waiting for that Board of Nursing application to be processed and for our certificate to be granted. So once we receive that certificate, the lifetime offer will end. So if you are a nurse, be sure to go over and grab that so you don't ever need to do another review course again. And if you're a medic, EMT, future critical care provider, might as well take advantage of the opportunity now. There's 32 hours of continuing education that you can apply towards your national registry and state. And for your nurses, once that accreditation comes through, we'll apply that to your accreditation, your ability to submit those hours as well. Cool. One last time, I'm going to throw that QR code back up on the screen, and I'll leave it up there for just a couple minutes because I'm sure you don't want to look at two of me. I don't want to look at two of me, and I'll have to work on that. And you guys can check that out. And of course, that'll be up on the website as well. All right. That's all I have. Hunter, you have anything else you want to add?
I don't. Cool. I got nothing. That was fun. Guys, reach out to us. We are here to help you answer your questions and whatever you need.
Cool. That's all I got.
All righty.
All right.
Thank you, guys.
Thursday, oxygenation, ventilation, and lung protective strategy.
Yeah, we're going to get our vent on, so come say hi.
Yep. Cool. All right, buddy. And everybody else watching, thanks so much. We'll catch you Thursday.